Hi, everybody. Welcome to Cannabis Use Disorder for the Healthcare Professional. My name is Megan Bang. I'm a registered nurse. I'm the founder of Trusted Canna Nurse, and I am a candidate for Master of Science in Medical Cannabis Therapeutics. Today, we are covering cannabis use disorder from a nurse perspective. This is a more holistic perspective than a provider perspective, usually. And we take a patient centered approach. So, this is definitely applicable to providers as well. So let's get into it. What is cannabis use disorder? This is a condition generally characterized by the inability to stop using cannabis despite negative health or social consequences. This is a very nuanced and very delicate subject, which is why I'm choosing to record instead of just present the slides. Cannabis use disorder has also been referred to as addiction or problematic use or dysfunctional use. As a nurse, I'm not giving a diagnosis, I'm not throwing on a label, but we do support patients who come to us when they realize themselves that they need help and they have a problem. In looking at the prevalence, the numbers in the literature are kind of all over the place. One recent study said 20% of adolescents develop CUD within 4 years of initiation. This same study said that, like, as the prevalence of cannabis use in teens increased, like the treatment of CUD has decreased. It's generally known that that all users carry a lifetime risk of 9%. But the medical, patients who are using medically, we don't exactly know the prevalence. And a lot of the studies, in fact, almost all of the studies do not consider the route of administration or what the patients are taking. Um, and what we see, when patients are coming to us, they're reporting that they are doing, inhalation is their primary route of administration, and they're doing THC rich products like dabs, concentrates, and vape pens. We aren't seeing a lot of patients coming to us as much with like edibles or tinctures, of course, not topicals or other routes. So we're just seeing higher routes, or sorry, more people coming to us with inhalation methods. And I do have curiosity around, does the prevalence of CUD increase with those who are using, who are inhaling THC rich products? In looking at the risk factors in the literature, it says the initiation in adolescence is a risk factor. Being male is a risk factor. However, in practice, we get a lot of women. It is majority women who are coming to us, and that could be multifactorial. Um, Most of them are using THC-rich products regularly, daily or almost daily. Um, History of psychiatric treatment, parental substance abuse, poor school performance, and childhood sexual abuse. We see when patients are coming to us that they are coming to us and using cannabis, as a way to cope with their difficult emotions, to numb out, or to deal with a history of trauma. Um, and this is consistent with what we see um, in some of the literature as well. In diagnosing, we have very limited tools. We have the cannabis use disorder identification tool, and then the DSM. So let's look at the CUDIT. This is just a screening tool to be further evaluated by the DSM. This is 8 questions, and this is based primarily on current use. Medical patients have a high likelihood of scoring high on it because it does not differentiate between medical use and recreational use. So it's not necessarily an indicator of problematic use. And this tool does not address, the underlying or the driving factors behind why people are using cannabis, and why they're choosing to continue to use, despite negative consequences. So, if they get a certain score on this tool, then they're oftentimes referred out for diagnosis of the actual cannabis use disorder. So, this is a DSM diagnosis. This has 12 yes or no questions. Depending on how many they answer yes to, it can be classified as mild, moderate, or severe. Um, and this also does not account for medical use. It does not assess any risk factors or any underlying and driving factors behind the use. So this is where I caution, providers to approach this delicately, because when patients have a diagnosis of CUD in their chart, it can have implications. So a benefit of it is that, if they have this diagnosis in their chart, then insurance is more likely to cover treatment of it. However, if the patient is not ready for treatment, then it may not have benefit to be in their chart. But also, this having this diagnosis in their chart can risk, um, you know, it may impact their ability to get other treatments, such as pain medications, and they can be really severely stigmatized in the healthcare system by having this diagnosis in their chart. So we urge providers, those who are diagnosing, to take this with caution and delicately, and just consider the implications of having this diagnosis in the patient's chart and in their history. So I'm going to go on to our approach. And again, we are a team of nurses. We are not diagnosing. The patients come to us wanting to cut down their use. So the questions, what we do, our approach is just to get curious about the patient and their use. And we ask questions to help them bring awareness to their own use. And we use motivational interviewing to do that. Some questions we ask is, how do you feel about your relationship with cannabis? If you could change one thing, what would it be? Does cannabis help you function more, or does it help you function less? Are they using cannabis so that they can get up and go to work every day because they're not in pain? That's sounds like it would be a functional relationship. Or are they using it to numb out, and they're staying in bed all day and not being productive? Um, and is it solving problems, or is it contributing to problems? Is it contributing to maybe stressors in relationships, or other things like that? Are you using it to escape and or numb out from emotions or difficult times? So all of these questions are just to help the patient bring awareness to their own use. And then we want to gauge their interest in making changes. A lot of people are happy with their relationship with cannabis and don't have any desire to make any changes, in which case a diagnosis, may or may not be effective, or it's not going to do anything to have a diagnosis if they're not willing to change. So do they see their use? If they don't see their use as a problem, then they're going to be less likely to make any changes. So we refrain from labeling them with a diagnosis, one, because it's out of our scope to do so. And we find that, labeling with a diagnosis, um, just it kind of ostracizes them even more. And then we offer education in relatable terms that they can understand. We educate them on the ECS and why their receptors have downregulated and why they need to continue to use higher doses. And we teach them about how tolerance works and maybe how they could benefit from a tolerance break. And supportive interventions that we have found in our practice. We are 100% supportive and understanding of our patients. We are not judgmental. We're addressing underlying factors. We're suggesting, if extreme stress or trauma is the reason behind their use, then we're going to suggest therapy or some sort of specific trauma support. Psychedelic integration has been really effective in other addiction models. And we're seeing research, or we're excited to see research on the use of psychedelics for cannabis use disorder. Um, and other supplements that can help with withdrawal symptoms. And acetylcysteine has been shown in an older study, a smaller study. It can help. Um, Sorry. Um, NAC works by regulating the release of glutamate, thereby decreasing cravings and compulsive drug seeking behavior. This study in 2010 found that 1,200 milligrams twice a day was shown to significantly help people in decreasing cannabis use and cravings. And this is a small study and an older study, but we're seeing NAC a lot in treatment of addiction of other substances. We encourage patients to use magnesium to help regulate their nervous system, especially in the immediate phase of coming off of THC. And then we have a curiosity around CBG to see if CBG can help with with the withdrawal symptoms because of its unique action on receptors involved in our fight or flight response. And then group support can be really effective in helping people to get through their tolerance breaks. And then we're helping them optimize their cannabis use for their symptom management. And that means we're teaching them the difference between resin and rosin, and higher quality tinctures, and getting away from the inhalation if they need a longer acting, um, a longer acting management. Um, and I would like to point out that with the trauma support, there was a study recently that found that an adverse childhood event was directly related to, and they called it a causative factor in developing addiction and other mood disorders later in life. So we are definitely looking at adverse childhood events and adverse events as driving factors, and we are addressing those. Um, so we are going beyond just the immediate use. In looking at resources that patients have available, there is a marijuana addiction helpline. There are many resources out there. This is from the American Addiction Centers.org. There is Marijuana Anonymous. And as a business, we offer support groups. We are testing a group right now to see if different interventions can help people cut their use. So there are many, many sources out there. I'm going to go back to the interventions. Um, in a lecture, I saw that gabapentin was being prescribed to help people who suffer from cannabis use disorder. Again, that's not in our scope to prescribe. However, we know that gabapentin can cause many, many issues for a lot of people. So just looking at like the actual side effects and long-term effects of certain prescription medications, and to tread cautiously with those, and to maybe not just throw a pill at the problem, but to actually look at um, to look at the whole picture of the patient and the underlying and driving factors, and to see what can be most supportive for the patient instead of just a prescription medication. Um, and my final thoughts here: we want you to work with the patient to improve their quality of life. Be cautious of an official diagnosis. Is it going to help them get treatment, or just further stigmatize them? Be cautious. Get curious about the patients, and ask them questions to bring self awareness. Offer support if they are ready. If the patient is not ready to make changes, then they will less likely to be open to support. We want to address the underlying factors, and we want to treat the patient and not the diagnosis. So those are my final thoughts on cannabis use disorder. I would love to know your thoughts. Here are my resources that I used for this presentation. And thank you so much for watching.